Dear colleagues, thank you very much for the opportunity to act as a second speaker. In fact, I'm the third speaker, but Bernhard is still on his way here, so I will try to fill the gap. So 10 years of meeting, that's always a good time to look back, and I think the most satisfying event that can happen in a professional life is to be part or even the driver of a practice change. You have very nicely shown this, and certainly you fulfill into this category of scientists or neurosurgeons. And I think it would be also a good time to look at the history of the technique that you are all fond of, that you are all using, and this is navigated transcranial magnetic stimulation. And this is also to honor those that have really started the spark or have been the first on the set. And this wasn't certainly me, because I was coming from Mannheim in 2007, and we were certainly not in the leading field of electrophysiology. That was rather a minor focus of ours, and I wasn't certainly experienced. So I was very happy to find a group of experienced young neurosurgeons that were interested in electrophysiology. You have named Theo Kombos. Olaf Süß is certainly one of those, and obviously Thomas Picht, who has published the first paper on transcranial magnetic stimulation in the hands of neurosurgery. And interestingly enough, this has been another technique, line TMS, and not the technique that we are currently using. But interestingly enough, this was the first application, and Thomas told me that it took him more than 2 years to find a journal that would publish this paper. You started with Neuroimage. I was kindly put there as a co-author, and then in the end we had nice reports in neurosurgery, and you find all the names that were the opinion leaders in the field, and nobody of those was really negative. They were all positive and supportive, but I think nobody had really had an idea of how this would develop. And then the next paper was with the technique that you know, with the E-field TMS technique, and these were the first patients that were treated. And I think these two, the one that I've shown you before and this one, are certainly the landmark papers and really show what Berlin is proud of, being one of the first or the pioneers of bringing that technology into neurosurgery. And this has to be acknowledged to the people that I named and to the company that has supported the first models of the system. And by that time, gladfully, it wasn't so difficult to find the machines as it has been previously. And then meanwhile, many of these patients had been stimulated, and the first validation paper that came out was comparing TMS with direct cortical stimulation, fMRI, and showing that it's superior to fMRI, and this has been recapitulated by many teams meanwhile. I think the next step was, and that's where I really started also to understand the value, not only do the cortical localization, but using the results as a seeding point for the tractography and having a more defined and more precise tractography that could be used for preparing someone, the neurosurgeon, for subcortical stimulation, to having a better risk adjustment, and also to having a better field of the risk that was associated with removing tumors. And by that time, we already had mapped quite a number of tumors, and we started the first comparison, which was obviously not randomized, but it was like a retrospective case series. Maybe one center or one department was using less of the technology than the other, or one surgeon was reluctant of using it, so we could start to compare. And this was really the first idea that we got, that it was clinically meaningful, and this was really the base of the further studies and the current studies ongoing, suggesting that we could, on the one hand, improve the grade of resection, or be more aggressive on the resecting tumors, and tumors that you now consider as being operable. By that time, 2007 or even further, were categorized as inoperable, especially in the motor area. And TMS was really helpful. And this risk stratification has been already shown. And then I should mention, and now the names are popping up that are now residents and faculty at our department, like Tizian, a young resident now. And he really, together with Thomas, came up with a risk assessment, and with the whole team that was contributing, that is now giving us an idea of when can we resect the tumor safely, how can we consult our patients, And even if we feel that it's a high risk of doing it, we still feel it's worthwhile going in. So we have turned into a very aggressive surgical strategy. Also, our mentality is like this, but also TMS helped us to be on the safer side and then see how far we get together with electrophysiology, together with intraoperative neuromonitoring with direct and subcortical stimulation. And the next thing that I thought was really helpful was improving the tractography and working on the speech areas. We're not yet there with speech mapping, where we are with cortical mapping, but certainly we have made advancements, or we have made developments there. Especially, and this is again an effort, Thomas has started to work together with linguistic groups, and I think that was a very differentiated approach to language mapping. The regular neurosurgeon was happy if the patient could walk or talk after the surgery, but understanding the details of speech production and understanding and the linguistics behind it has really contributed to the whole field. And this was really a side effect of the TMS, using the TMS in our clinical scenario. And this is where we are now. We are working on an improvement of our tracts. We are using different algorithms, and we have recruited co-workers that are not necessarily neurosurgeons, but let's say illustrators or computational neuroscientists. And meanwhile, we are now looking at the tractography in a very more differentiated way than we did before. And I think this is, again, the group has to be acknowledged, and this all started with TMS, and this shows how it changed neurosurgical practice, at least in the neuro-oncology field. But not only in the operative neuro-oncology field, also in the radiosurgical field. Together with Markus Kuhfeld and Thomas Picht, and also Alfredo Conti, who is now with us, and we are very glad about that. We thought what might work for neurosurgery might also work for radiosurgery or for CyberKnife surgery or for, you name it, what kind of radiosurgery. And the idea was really to identify, before applying high doses of radiation to the brain, to identifying the risk areas. And again, TMS seemed to be an ideal tool for that. That is a case of a atypical meningioma. Patient had been operated before. This is a recurrence. Patient was reluctant to be operated. He decided to undergo radiosurgery, and the mapping gave us an idea about the complexity, both if we would do neurosurgery or if we would do elect for going for radiosurgery. And here we have delivered quite a high dose together with the TMS data, and that made non-surgical, and our non-surgical approach to tumors or to oncology lesions, again, more differentiated and maybe even more safer. Another case that is really showing that with CyberKnife we could control the lesion, and we were maybe less risky and had produced less side effects than with a reoperation. And then we became intrigued to find other applications. I always feel that we should not limit TMS only to neuro-oncology. We always strived to have other indications. And number one were the vascular indications. And we started with brainstem cavernomas. And the idea was to use the tractography not only for having an idea for supratentorial lesions, but also for using it for brainstem lesions, not only tumors, but as I mentioned, also for cavernomas. And the tractography has proven to be much more precise than a regular DTI imaging. There are papers out for the usefulness of DTI imaging in brainstem cavernomas, but clearly producing very precise tracts with the TMS is way superior than a regular DTI tract for a brainstem lesion. And at the same time, we were looking at AVMs. AVMs have the problems that they are frequently localized in eloquent areas. We might argue that once we have started to operate, we cannot go back, different from a tumor. And therefore, the risk assessment preoperatively is really critical. And functional MRI, on the other hand, doesn't really work because the bolt sequence is not reliable in these arterialized lesions. The veins, the draining veins are arterialized, and therefore we cannot use the classical functional MR imaging. And therefore, we thought that this would be an ideal indication for TMS, for mapping of eloquent areas around AVMs. And one of our Japanese fellows and visitors was very successful in producing a case series that has proven that TMS has really a very high strength in this non-oncological application like AVMs. And again, back to CyberKnife, it's not what not only works, what works for oncology patients also works for vascular lesions. AVMs in eloquent areas can be nicely mapped also with TMS, and they also give us an idea about not only whether these AVMs are resectable, also about the risk profile when we apply high doses of radiation, but also about the modulation of the dose, about the physics of radiation. They are also taken into consideration, and TMS is helping us here again very much, and we could treat lesions like that we elected not to operate by a CyberKnife. And the next idea was to go away from simple mapping and from function localization to understanding neurophysiology of the brain under pathological conditions. And while we are not experts in neurophysiology, we always had an interest in chronic ischemia and revascularization, and we were always frustrated that bypass surgery had proven not to work for the classical atherosclerotic carotid artery occlusion. And we have used xenon CT and water PET in order to assess the reserve capacity of the brain in these chronic ischemic patients. And the next idea was, why not use TMS and see what comes out of it? It really was an exploratory approach, and the idea was maybe to have another hint that would support that bypass would maybe help ischemia and that chronic ischemia is doing something bad. I mean, these patients are not only at an increased stroke risk, these patients also have significant neuropsychological or neurocognitive impairments, and maybe TMS would help us to have an idea about that. So we used TMS, and Anna, that is today a resident with us, has published this paper, and the initial idea was in neurology we only have a black and white idea about the brain. Either the brain is intact or you have a stroke. In contrast, in cardiology, we know the phenomenon of a stunned heart or a hibernating heart. That means we have a chronic ischemia situation with a high-grade stenosis, and this results in an impairment of cardiac output in the muscle activity or the contractility of the heart, but still there is no stroke, and this is a reversible situation. By either stenting or by either producing a bypass, this would go back to normal. And this was really the idea, why shouldn't there be a hibernating brain as well? And we thought that TMS would be the right technology to study this, and admittedly, we formulated this hypothesis after what we have seen, what TMS results were produced in these patients. But if you see a patient like that has not a stroke but is suffering from repeat TIAs, has an increased stroke rate and has a neurocognitive decline, and obviously has an MCA occlusion, and then a bypass is performed and the patient goes back to normal, and at the same time the resting motor threshold, which has been very high compared to the healthy side, is going back to normal, we thought that maybe a preoperative TMS evaluation would give us an idea about about whether the patient needs a bypass, and to understand the concept of hibernating brain, whether this is true. It's not only the resting motor threshold, we also learned that patients that were chronically ischemic were activating their brain plasticity, and maybe were doing so well because they were able to increase the area of the motor activity. And this was increased in patients that needed a bypass, and following the revascularization, this was condensed again, which gave us an idea that this was a reversible process, and it gave us also an idea that an increase in the motor activity would be a surrogate or a readout of the loss of reserve capacity. And this was, as I mentioned, reversible. We have studied atherosclerotic patients. Meanwhile, we have studied Moyamoya patients. We have treated 300 Moyamoya patients in the last years, and they seem to be different. They also have an increased motor area, which is normalizing following the revascularization, but the mechanisms and the consequences on the RMT seem to be different, and we are still in the process of understanding this. However, it seems that the recovery process of the hibernating brain seems to be different in Moyamoya patients. The hypothesis is that the hemodynamic stress and the potential to compensate, maybe because the patients are younger, is higher in Moyamoya patients. And this is maybe because this is also maybe the reason why they are tolerating more strokes than atherosclerotic patients. We moved on to the spine, and the idea was to find indications in spine. And there we worked on cervical myelopathy. We are well aware that the clinical manifestation of cervical myelopathy is primarily sensory. But on the other hand, haven't you ever asked why is it sensory and why are the patients doing so well for a long time on the motor side? And the one answer to that could be that they are compensating on the motor side. We have developed the concept of the corticospinal reserve capacity in analogy to the cerebral vascular reserve capacity. The brain is capable of compensating for some time for an impaired spinal cord function. That means if you have a chronic compression of the brain, we hypothesized that there is a corticospinal reserve capacity which allows the brain, at least on the motor side, to work, to function well for some time. And this is especially helpful for the mild myelopathy patients. We all agree that severe myelopathy patients or moderate myelopathy patients need a surgery. No question about that, especially if you are a neurosurgeon. The mild side is where we have a controversy, especially with neurologists and with neurosurgeons as well. And the observation is that some patients have a severe cord compression but are still doing well, and the others have a cord compression and have a mild or even a moderate. And the hypothesis is that in the big group of mild myelopathy patients, there are some that have a mild cord compression and do not need a surgery because the natural history is maybe benign. And there's another group of patients that have a significant cord compression, are still mild in the clinical appearance, but the reserve capacity is already exhausted. And if we wait a little bit longer, they will decline, and we should operate these patients. This is the concept that we have published in this paper, and these are two illustrative cases. Number one, patients with a T2 signal, mild to moderate cord compression, doing not so well, moderate to severe myelopathy, and this patient has a very small motor area. Just focus on the motor area. All the other parameters are not very, very useful here. And this patient is still doing well despite the same MRI, and his motor area is much bigger. And the idea was that this patient is compensating whether the other already has exhausted and is not doing so well. And this was confirmed again by Anna in her paper. And what she could show is that we have to look at both M1, M2. Gladfully, we did a large mapping in all the patients. And in healthy patients, all the cortical responses come from M1, while M2 is not needed. And the reserve capacity works in a way that while M1 is reduced, M2 is recruited, and for some time is able of keeping up the cortical input and the activation of the corticospinal tract. And only if patients are decompensated on a clinical basis, they are decompensating because they are losing both M1 and M2. And this is shown again here. Patients that are doing well have not so much M2. They are increasing M2 while they are compensating, but the motor capacity is staying the same, and also the clinical manifestation is staying still mild, and at some level they will decompensate and they will become severely affected. And the good news is that this is again reversible. This is a patient, this is pre-op, this is post-op, and here you can see how they are regenerating or how they are going back to normal. And if you ask me, in my eyes, this is another very exciting concept, and we are looking forward to our ongoing multi-center trial where we are trying to confirm that we have something in analogy to cerebral vascular reserve capacity. The motor area is increasing, keeping up the motor function, and if the reserve is exhausted, and we should operate the patients before the reserve is exhausted, and TMS is the only technique to identify the reserve. So in conclusion, I think we have seen 10 very exciting years of TMS. In our eyes, navigated TMS is among the most important adjuncts in glioma surgery, and there we have already seen a practice change, and I think Thomas, Olaf, and Theo can be very proud of this. It seems to be helpful also in planning neurovascular cases, and it has the potential to change the current concepts, especially in degenerative cervical myelopathy. Thank you for your attention.